Hi, everyone. Thank you very much for giving me the opportunity of presenting in this very interesting symposium. I'm only really sorry I can't be with you to present in person. I'm going to talk to you about a trial that we've done of baricitinib in new onset type 1 diabetes called the BANDIT study, and I'm going to talk particularly about some of the 2-year outcomes of the data. First of all, I want to acknowledge all my collaborators in this trial that we started several years ago now. In particular, I want to acknowledge Helen Thomas, who was my scientific co-lead in the study, and also John Wentworth, who was one of the main site investigators. Not mentioned on this slide is Michaela Weibel, who was mentioned on the previous slide, who was the project manager for the study. It was an investigator-initiated trial, and it was supported by Breakthrough T1D, formerly JDRF, Juvenile Diabetes Research Foundation. The drug was provided by Lilly, but Lilly did not play any part in the conduct or interpretation of the study. And the study was done at 4 trial sites in Melbourne, Australia, and 3 in Melbourne, Australia, and 1 in Adelaide in South Australia. Okay, so the aim of the work that we do is that we're trying to develop a new approach to treat type 1 diabetes that will protect and restore the human body's natural processes for insulin production and blood glucose management. And the reason we want to do that is shown in the following slide, which comes from the data from the BANDIT study, which shows the relationship between C-peptide production and time and range on CGM in the subjects, in the participants in the BANDIT study. And you can see that there's a strong positive correlation between C-peptide, that is a measure of endogenous insulin production, and the time in range. So the more endogenous insulin production you have, the better the range of glycemia is, and of course that comes with many benefits, and hopefully also comes with less burden of using exogenous insulin. Now, I have a very simple way of thinking about the autoimmune response that occurs in type 1 diabetes, and that's going to be shown in this video micrograph. And what you're going to see is that that autoreactive CD8 positive T cells, that cytotoxic T cells, they recognize and kill insulin-producing beta cells. And the T cells here will be in green because they are stained with a calcium fluorophore, and the insulin-producing cells will be in the center of the field. And you'll be able to see that the T cell flashes green when it recognizes the beta cell, and it forms a strong attachment to the beta cell and stays there until the beta cell turns red, indicating that it's taken up dye from the medium, showing that the cell is dying, and then the T cell goes off and kills another beta cell. And that's really the final common pathway of the damage that's done to the beta cell by the immune system. And it's been our goal over many years to disrupt what we would call this immune synapse that occurs between the T cell receptor and the MHC class 1 molecule presenting antigen on the surface of the beta cell. Now, these slides tell you that upregulation of MHC class 1 or HLA molecules, with the human name for these molecules, is that's seen in type 1 diabetes, a hallmark of type 1 diabetes. And you can see on the left some histology from the work of Sarah Richardson in the UK, showing that in islets taken from type 1 diabetes donors in the bottom panel, you can see increased expression of HLA-ABC and increased expression of STAT1, a transcription factor which induces the regulation of HLA-ABC in these islets from an individual with type 1 diabetes. Whereas in the non-diabetic islets, islets taken from a non-diabetic donor, you don't see the same characteristics. And Helen Thomas in our group was able to show that this upregulation of HLA molecules on the beta cells, shown here in this flow cytometry plot, you can see that interferon gamma upregulates HLA-ABC on the beta cells. And when you add a JAK inhibitor, which is the kind of drug that we're going to be talking about in this presentation, that the HLA-ABC drops back to baseline levels, indicating that and these and other data indicate that the increase in HLA-ABC is due to interferon gamma acting via the JAK-STAT signal transduction pathway. Now, not only that's, and the JAK-STAT signaling pathway is shown here. You can see that the JAK-STAT molecules, the JAK kinases, are downstream, of which there are 4: JAK1, JAK2, JAK3, and TYK2. They are signal transduction molecules for many different cytokines and hormones. And you can see for type 1 cytokines, such as these, including IL-2, IL-4, IL-7, IL-9, IL-15, IL-21, all members of the IL-2 family of cytokines, that the JAK-STAT signaling pathway is downstream of those cytokine receptors, and that's also true for the type 2 cytokines such as interferon gamma. And because of the involvement of these IL-2 family cytokines, the JAK inhibitors block the activation of T cells by these cytokines. So they act in type 1 diabetes. We think about the JAK inhibitors acting in two ways. One, by blocking the impact of interferon gamma on the pancreatic beta cell, reducing the level of expression of HLA molecules, making the beta cell less visible to the cytotoxic T cells. But the JAK inhibitors also block gamma common cytokines, gamma common chain cytokines of the IL-2 family, and this reduces activation of effector T cells. So it's the two ways, the two bases that we had, the two rationales that we had for trying these drugs in type 1 diabetes, in human type 1 diabetes, which we did only after many years of showing that they're effectively able to prevent or reverse diabetes in the NOD mouse model and various other settings in experimental models. So JAK inhibitors have been used for about 15 years, and they've been approved for a variety of different diseases, and several different classes of these drugs have been approved with specificity for one or multiple JAK isoforms. Shown here, the drug that we use, Baricitinib, is specific for JAK1 and JAK2, and the drugs are approved to treat a variety of immune system diseases, notably including rheumatoid arthritis, inflammatory bowel disease, but also notably they were used during the COVID-19 pandemic to reduce the impact of cytokines in the in people with severe COVID-19. There are also ongoing drug development studies where new JAK inhibitors are being tested, including in newly diagnosed type 1 diabetes, which is the setting in which we use JAK inhibitors. And the trial I'm going to talk to you about has been published. It was published in the New England Journal of Medicine at the end of 2023, but we've not yet published the data. I'll show you about the 2-year follow-up study, and these are the main references to the BANDIT trial so far. So this is the consort diagram, and here you can see that in this phase 2 randomized controlled trial, we randomized 91 participants, and they're allocated to Baricitinib, 60 people, and 31 to placebo. And they were treated for 48 weeks, roughly 12 months, with drug, and then 48 weeks of follow-up after drug had ceased. Now, a few characteristics: they'd had to be diagnosed with type 1 diabetes, clinical type 1 diabetes in the past 100 days. They included females and males aged 10 to 30 years who were islet autoantibody positive, one or more of GAD-IA2s, zinc transporter 8, and insulin autoantibodies, and they had residual C-peptide. Almost everyone at the onset of diabetes has C-peptide levels of greater than 0.2, but usually significantly more than that. And most of the people in the study remained in the study. Most of them remained through the follow-up period. This shows the main primary outcome of the trial, which was to do with measuring C-peptide in response to a standard mixed meal tolerance test. That's the usual way that these interventions are tested. And you can see in this slide on the left that the drug was used for the shaded period of time between 0 and 48 weeks of age. And then the drug was ceased and the participants were followed up. And in the shaded time on drug, the C-peptide was significantly greater in the baricitinib treated participants at all times, at all time points, 3 months onwards, in the treated period. And these, even though it looks as if it goes up a little bit and comes down a little bit, in fact, these blue dots, they are there's no significant difference between all of them. And really, what we conclude from this is that the on treatment, the C-peptide production, the endogenous insulin production stays stable, whereas it drops away, as you might expect in the placebo treated subjects. And in that period, the increased level of insulin production was correlated with a reduced exogenous insulin requirement. Because the people who are being treated in this study have diagnosed clinical diabetes, few of them actually become insulin independent. Again, just a handful of people in the study, and we could come back to that in the question period. I guess the main focus there is treating them, starting treatment earlier than when at the time of onset of diabetes. We also don't know how long this positive therapeutic effect would go on for. We only treated them for 12 months, and at some point in the future, we'll need to test how durable that positive effect is. Now, you can see when the drug is stopped, the participants who were previously on baricitinib begin to lose insulin production, and although it's still statistically significant at 72 weeks, no longer statistically significant at 96 weeks. And this shows that the drug needs to continue to be taken to be effective. And while some would see this as a little bit of a negative, you would like to take a course of treatment and then be fine indefinitely, that's an unusual and possibly at this stage of our knowledge, an unrealistic idea. And certainly with baricitinib, the idea is you need to keep taking it. And the fact that the C-peptide begins to be lost when you stop it reinforces the idea that the drug was, in fact, effective. Now, we did not see at any stage in the time of treatment a difference in hemoglobin, a statistical difference in hemoglobin A1C, but we did see a change in glycemia measured by CGM, continuous glucose monitoring, parameters such as variability, parameters such as coefficient of variation, and time in range. And again, you'll see that these curves came together once the drug was stopped. Now, one way of comparing and looking for people who are responders versus non-responders is to look at a parameter called the quantitative response score, which uses the participant's age and their C-peptide to work out what the expected C-peptide will be 12 months after diagnosis. And you can see that in our placebo group, the placebo group was really bang on 0, which is the expected number for the quantitative response score, whereas the quantitative response score in the baricitinib treated participants was substantially substantially and highly statistically significantly greater than 0, consistent with the idea that the drug was effective in the baricitinib treated participants. About 2/3 of the baricitinib group were responders, which you could use as a definition of that. There are many definitions of responder. The people who were above the level of 0, above the expected quantitative response score. But there are other ways that we measured response too, and roughly 2/3 of our baricitinib treated participants were responders. About 1/3 were not responders. Actually, more than 2/3, 48 versus 12. And this just shows one of the many ways that we've gone out to analyze the response that people have to the drug. And here is using an assay for stat phosphorylation based on flow cytometry assay. So baricitinib is expected to inhibit stat phosphorylation. And you can see here in people with peak baricitinib levels 2 hours post taking the study drug, that there was a statistically significant drop in the phosphorylated STAT3 in the peripheral blood of people in the study, consistent with the known effects of baricitinib. We looked at a whole bunch of baseline predictors of response, and here's this forest plot, and it shows that most parameters did not reach statistical significance, and we do not have any at present robust predictors of response at baseline. There are a couple of things that popped up as approaching statistical significance, but with a very large variability. One was body mass index, where a body mass index of greater than 30 appeared to be suggestive of poorer response, and here also adherence to medication appears to be a factor as a predictor of response, although again it didn't reach statistical significance. But after all, it makes sense that would be the case, and there are definitely some people in a trial like this who are not able to adhere to the medication sufficiently for it to work well. Okay, so at this point, I'll just go through some of the conclusions from the BANDIT study. It's effective in baricitinib, a single daily tablet of 4 milligrams a day, is effective in preserving C-peptide on treatment. It's well tolerated. There were few side effects. I haven't gone into those there in detail in the publication, but suffice to say is there were really no more side effects. In fact, fewer side effects by chance in the baricitinib participants. The effect of the drug wanes once the treatment is stopped, which is also positive from the point of view of side effects. Treatment works in adolescents and adults. I haven't shown you the data for this. We did a post hoc analysis of this, and we found no statistically significant difference between how the drug worked in adolescents and adults, and we've not found any baseline predictors of treatment response. Larger trial cohorts are going to be performed to confirm the BANDIT results, and many more analyses are going on in the lab to try and understand what might determine a positive result to baricitinib treatment. We did not carry out formal patient reported outcome measures in this study, but I'll give you a couple of testimonials. The mother of Anna, age 12, in BANDIT, and an older brother, age 16, both of whom have had diabetes. She says, in the first year, in fact, nearly 3 years have been so much easier than our previous experience. That was a really tough time, probably a combination of things. However, I'm sure the study drug was the main contributor. At visit 12 to 48 weeks, Anna's hemoglobin A1C was 5.6%, and her insulin dose was 0.2 units per kilogram per day, and her C-peptide remained quite substantial. Similarly, the mother of Finn, aged 14, in the BANDIT study, who also had an older child with diabetes. Thank you so much for everything you've done for Finn. I have no doubt that it will make a profound difference to his long-term health, and perhaps if his T1D is easy to manage, of just as much benefit will be the improvement to his quality of life, not to mention his father and myself. At visit 12, Finn's hemoglobin A1C was 5.7, and insulin dose was 0.28 units per kilogram per day, and his C-peptide remained also substantial. So in conclusion, the way we're thinking about this is we believe that in a nature first, if you like, treatment model, where the clinician and the patient work together to determine the treatment pathway, the best treatment pathway for that individual, with the aim of maximizing health outcomes by first preserving and protecting the body's natural function. Using a drug like baricitinib to protect beta cells and to some extent to revive their function, And this could be a first line of defense, especially for newly diagnosed people with type 1 diabetes. In the future, beta cell replacement, perhaps with stem cell-derived islets, will be used to restore insulin production. For the people with more progressed type 1 diabetes, the option will be to restore beta cell function with stem cell-derived islet transplants, either derived from their own autologous cells or from donor cells. And of course, there'll be ongoing use of insulin administered by pump and injection technologies. There's always going to be an ongoing role to support natural endogenous insulin production with top-up insulin, including after stem cell-derived islets and so on. So this is a slightly futuristic idea of where we'll be with treating type 1 diabetes in the future, and I hope it makes you think about how things might change and improve the outcomes for your patients with type 1 diabetes. Thank you very much for your attention.